Hello, everyone. Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for April 17, 2019. Thank you for joining our presentation this month. Our presenter today is Dr. Carol A. Oatis. Dr. Oatis is a professor in physical therapy at Arcadia University. She has taught in kinesiology and biomechanics. Her research focuses on issues relevant to patients with osteoarthritis. She currently has federal funding to investigate the role of physical therapy and patient participation in functional outcomes post total knee replacement, TKR, surgery. Welcome, Dr. Oatis.
Thank you, Haley. Thank you for that introduction, and good afternoon or good morning, everyone. As Haley said, this is a study of physical therapy following total knee replacement. So what I'm going to be telling you about is a small part of that study, PT for TKR. The overall study is designed to quantify outpatient physical therapy and patients' home participation following total knee replacement. And then, after adjusting for all of the patient factors, identifying what patient factors or participation factors and what physical therapy practice factors are associated with positive outcomes at 6 and 12 months following total knee replacement. So most of us know that functional outcomes vary at 12 months, and my colleague Patricia Franklin published this paper over a decade ago that shows that the solid blue line shows the SF-12 physical function scores prior to surgery, and then at 12 months after surgery. And you can see there's this substantial number of people, up over 36% of the sample, had little or no functional improvement. And when I was talking to her about this, she was looking at factors that could explain that loss of physical or lack of improvement in physical function. She was looking at patient characteristics, surgery, and so on. And I said, well, have you looked at physical therapy, at rehab, and how that accounts for everything? And she sort of paused and said, doesn't everybody get the same thing? And I and every PT colleague I've told this to afterwards sort of chuckled at that response and said, well, of course not, except we had no data to demonstrate that. So that was, we started thinking about looking at physical therapy. Does it vary after total knee replacement, and does it make a difference? At about the same time, other literature was emerging that created sort of a paradox. We knew that flexion range of motion was associated with functional behavior like gait and stair climbing. We knew that quadriceps strength following total knee replacement was associated with performance measures like time stair climb, 6-minute walk, as well as the patient-reported outcome on the WOMAC. At about the same time, information was emerging that suggested that physical therapy exercise after total knee replacement yielded very small and short-term gains compared to usual care. So since flexion range of motion and quadriceps strength respond to physical therapy interventions, how could physical therapy exercise not be helping with performance or improve function after total knee replacement? And in this last decade, another factor was emerging, and that was that surgeons, orthopedic surgeons, were saying, well, you know, patients don't really need to go to physical therapy after total joint replacements. And part of their argument was based on the results that I just told you about, that systematic reviews said PT didn't really benefit anything. So particularly in our region in southeastern Pennsylvania, surgeons were telling patients to get some kind of step activity monitor or use a DVD and exercise, and a year from their surgery, they'd be fine. Don't waste their time, and in fact, don't go through the pain of physical therapy. So the question is, does PT make a difference? And the first thing we wanted to do was find out what patients get following total knee replacement. So we actually did a retrospective study from another, collecting data from patients in another study. So we just got the PT records from patients following total knee replacement, and we were able to get about 120 records, and we pulled out all of the PT data, and we showed that, first of all, there really was large variability in what patients received in physical therapy following total knee replacements. There were only 5 exercises reported in over 110 records that were reported in 50% or more of those records. Similarly, there were the exercises there were more non-weight-bearing exercises reported in all of these records rather than weight-bearing exercises. So there was really a lot of variability in the PT exercise interventions that were occurring. And we also found evidence that suggested there really wasn't adequate dosage of the exercises to get positive physiologic responses. The median number of progressions of an exercise for weight-bearing exercises was 0 and 1 for non-weight-bearing exercises over the entire episode of care. And again, this was from over 110 PT records from 31 different treatment sites. We also were able to show, though, that the time stair climb at 6 months post-surgery was associated with the number of weight-bearing exercises and the number of weight-bearing progressions. So it suggested there was a link between functional outcomes and what physical therapy was provided. Now, there were clearly lots of limitations in that study. It was retrospective, relatively small sample. The population was part of a randomized controlled study of a psychological intervention. It was geographically limited. It was only central Massachusetts. It was really labor intensive to get the data. And the data extraction was limited because of the quality of the notes themselves. Besides those limitations, though, we presented this at national meetings, and PTs, physical therapists, had additional specific critiques. One was, well, every patient is different, and therefore the PT should vary. So they were not concerned by the amount of variation that we found because every patient is different. Additionally, they said, well, the patient records that we reviewed don't reflect reality. So, the PTs probably did more, they just never wrote it down. So we said, well, then how are we ever going to find out if physical therapy is effective? I think it's akin to asking whether an antibiotic therapy is effective without knowing the name of the antibiotic, the dosage of the antibiotic, and the period over which the antibiotic is provided. So I think we need to look at PT in much greater detail. And that's what we set out to do. We needed to create a prospective study where we had easy and feasible data collection for the PTs. And in that process, we would include adequate detail of the treatment. We didn't want to tell the PTs what to do. We just wanted them to do what they were doing and tell us what it was. But we wanted to collect that data in a quantifiable way. So we created our own data capture system. We had originally thought that maybe we could use electronic medical records, but every office has its own electronic medical record. And even in the presence of those records, the records rarely provided adequate information to really detail the intervention. So we created our own. We used a secure HIPAA-compliant web-based data capture system. We identified 8 intervention categories with treatment drop-down menus from which the PTs could select their interventions. We identified a total of 143 interventions possible, and each intervention then had a drop-down menu of its own for intensity and dosage of any given intervention. We also had a downloadable dictionary of interventions because we PTs have a tendency to have multiple names for the very same intervention, particularly in exercise. So we needed to have a language that every PT could use, and so we had this downloadable dictionary of interventions. This is what the intervention page looks like. Once the PT has logged on and identified the patient and the visit date, you see all of these intervention categories here, and the PT can click on any given category. So for example, clicking on the strengthening exercise category, and another drop-down menu appears. The strengthening exercise category is the biggest. It has over 60 strengthening exercises, all listed in alphabetical order. So all the hip exercises are together, all the knee exercises are together, and then things like squats or lunges are easy to find in alphabetical order. Once the PT has identified an exercise, like knee extension in sitting or supine, then the PT has this set of boxes that must be completed: repetitions, sets, and resistance, including none, so that we know the patient or the PT actually positively determined not to use a resistance rather than just forgot to add it in. Each of these exercise categories then has its own menu, and each intervention in the menu has its own set of parameters that need to be completed. Down here at the bottom, the PT can add in clinical notes for any information that affected the PT's course of care. For example, if the patient missed a visit or got sick or underwent a manipulation, we would want that information identified. So we've got a way to collect the PT interventions, and we need to link it to the patient outcomes. And what we have done is use the National Total Joint Registry housed at the University of Massachusetts Medical School and developed by my colleague Patricia Franklin. This registry is a national registry for patients with total hip and total knee replacements. It includes patients from over 200 surgeons across the country, and it currently houses data from well over 30,000 patients with total joint replacements. The registry follows the patient and collects baseline information from the patient, and then at 6 and 12 months, including patient-reported outcome data. So we're using the registry, and then we're linking it to the PT data. So this is a schematic of what happens. We use the registry infrastructure to get preoperative or immediately post-operative data, depending upon when we identify the patient. The registry follows the patient and gets 6 and 12-month patient-reported outcomes. And we then insert the PT intervention data in here when the patient is undergoing treatment. We're collecting patient data at baseline and at 6 and 12 months post-total knee replacement. We have the specific PT intervention data. Our goal was to get 20 to 25 PTs in 3 different geographical areas. That's southeastern Pennsylvania, Rhode Island, and central Massachusetts. And our goal is to have each PT collect data from 5 patients. That would yield 60 to 70 PTs and a total of about 300 patients, which would give us enough data to look at variations in PT and still adjust for the variations in patients. So currently, we've deployed this data capture system in 8 PT practices with 32 practice sites. We have 100 PTs using the system and 16 PTAs trained to use the system as well. We've oversampled the PTs because, particularly here in southeastern Pennsylvania, we've really seen a change in the practice patterns, and PTs are seeing fewer total knee replacements generally. So we've had to get more PTs who are finding enough patients. So we still expect to get 60 or 70 PTs who have a total of 5 patients over the duration of the study. Since we deployed the menu or the data capture system, we've added 2 interventions and we've revised 3 definitions. So we thought we had a very complete, robust menu of interventions, and I think we found that that has been the case, that we've only had to make these small changes in the data capture system. And one of the best things is that the PTs using the system have said that it's really easy to use, that they routinely marvel at how much easier it is to use than their own EMR. So this gives you a sample of the kind of data we can use. This is really superficial analysis at this point, but so this lists all of the, I don't expect you to be able to read those, but that's the list of exercises that PTs have reported in the system and the patients in blue who have used those exercises. And again, you see that only a handful of exercises are being used by more than 50% of the patients. And there are a whole lot of other exercises that are being used by a much smaller number. The question is that variation appropriate? We don't know yet. We'll have to look at patient characteristics and PT characteristics. But the point is the variation that we saw in our preliminary data seems to be borne out by the current study. Similarly, how exercises are used by patients also varies. So the x-axis identifies individual patients, and these are flexibility exercises, and you can see some exercises, some patients do little or no flexibility exercises, and other patients do lots and lots of flexibility exercises. Again, this variation is important so that we'll be able to determine how appropriate that variation is. So our preliminary impressions of what we've done so far is, first and foremost, it is feasible to capture this kind of grainy detail of PT intervention. And importantly, practice variation that we saw in our preliminary data appears to continue. And I think even at this stage in our analysis, we have some really important takeaways. PT really does appear to be varied. We need to find out the source of that variation so that we can identify how much of that variation is justified. We have to document practice in real gritty detail. Physical therapy described as this amorphous lump is inadequate in order for us to identify its benefits. Detailed documentation really is feasible across multiple practice sites and across many, many physical therapists. And without this kind of detailed intervention, it's really impossible to assess treatment effectiveness. So we come back to the basic question of, Is PT effective for total knee replacement patients? We don't know, and we're never going to be able to answer that without this detailed intervention. So we're excited about the possibilities of it. We're also excited that we believe this framework provides a system to analyze the variation in practice for physical therapy across all different kinds of diagnostic categories, not just total knee replacements. So that is our data capture system in a nutshell. I certainly would like to acknowledge our funding source as well as my colleagues and the consulting experts who contributed to creating the data capture system as a whole. And I would welcome any questions.
Thank you, Dr. Oatis, for such an informative presentation. Just a reminder, if you have any questions, you can type them in the chat box at the bottom. So while we wait for any questions, or if anyone has any questions, I do have a couple questions I would like to ask. The first one is, how does you generate the menu of interventions for the data collection process?
Yeah, that's an important element. Creating the menu took about a year. We started with the intervention list that we had gleaned from our retrospective analysis of 120 records. And so we compiled that list of interventions. Those were from PTs in central Massachusetts. We gave that list to PTs here in southeastern Pennsylvania and asked them to use that list and to add to it any other interventions that were lacking on that list. We took that list, revised it, and gave it to 4 national experts here in the US and asked them to do the same thing. They used their clinical colleagues and revised it yet again. And then finally, we took that new list and gave it to 2 international experts and asked them to look at the list and revise it yet again. So that process took about a year. It was an iterative process. And as I say, it came up with what we thought was a complete list and turned out to be remarkably complete.
Oh, wow, that's good. But thank you for answering my question. We have one other question in the chat box. Someone said there are sometimes pressures to eliminate unwarranted variation in practice. Do you have a sense that some kind of variation is warranted, and or does it matter?
That's a great question. Yes, I think variation does matter, and I think some variation is absolutely warranted. Our patients following total knee replacements are quite varied. Some have OA as a result of an athletic injury and they've remained active and they want to get back to activity, while other people have OA and have 6 or 7 comorbidities and they just want to be free of pain. And I think it's realistic to expect that physical therapy will vary depending upon the patient's comorbidities and health status, and also based on the patient's own goals. So I think variation absolutely should be expected. That said, I suspect that there is unwarranted variation as well. And as I say, when looking back at the 120 records, it was remarkable to see the variation. And so our goal is to identify what variation is acceptable. And it very well may be that we can identify interventions that are appropriate for some patients and are not associated with benefits for other patients. So I think that by having this granular look at the real components of PT, we can actually help explain and recommend the kind of variation that is reasonable to expect with the patients that are varied.
Well, thank you for answering that question, Dr. Oatis. We have a couple more questions in the queue. Another one says, will you be looking at variation at multiple levels, for example, within patient characteristics, within a given PT, within a practice, within a region? She asks because she wonders if there may be multiple factors at different levels that contribute to the variation.
Again, it's a great question. And yes, we believe we have the power to look at, certainly we have the power to look at variation on patients and variation among PT sites. We are collecting insurance information and so on as well. So that yes, we expect that we'll have the power to look at characteristics that help explain that variation. And as I said, we've got 3 different regions, so we will be able to look to see if there are systematic variations in regions. Again, our preliminary data said there was enormous variation in one single geographical area. So I expect that there will be variations for geographical reasons, PT reasons. We also have different kinds of PT practices in the study, so we're hoping to see if the practice type has an effect on the intervention. So yes, we are looking for other characteristics that will help explain the variation.
All right, thank you. Last question that I see in the queue. Are you collecting information pertaining to the patient's perspectives?
Oh, that's a great question. We are collecting information about what the patient is doing at home in terms of home exercise and physical activity. We actually did talk about collecting more information about the patient's goals and so on. And frankly, we couldn't afford to do that in this study. So we're looking at what the patient is doing, but we're not looking specifically at goals that the patient articulates. It's an important issue, but we're just not able to do that in this current study.
Okay, well, hopefully in future studies, when you get funding, that would be something good that the patients would be able to track for themselves.
Right.
Well, yes. Well, we would like to thank you again, Dr. Oatis, for joining us today. As you all can see, a poll will pop up on your screen. Just if you take the time to answer it, just to give us a little feedback on this Lunch and Learn webinar today, that would be greatly appreciated. And also, just a reminder for our chat next month, which would be May 15th, with our OA Action staff and our Walk with Ease grantee panel on notes from the field on implementing Walk with Ease. So thank you again, Dr. Oatis. We really appreciate you.
Thank you very much. And thank you, everyone, for being on the webinar.
All right. Well, thank you so much. Thanks, everyone.
Bye-bye.
Bye.